Hello, everyone, and welcome as people start coming in. We're happy to have you all here tonight. We'll just get started in a couple minutes. Hey, everybody. Thanks for coming. We're just waiting a couple minutes for people to finish trickling in on Zoom. Thank you again for being here tonight. We're really excited for tonight's topic. All right, let's get started. Good evening and welcome everyone to our third session of Mini Med School this year. My name is Kevin, and we are really happy to have everyone back in person and virtually. Tonight's topic is going to be a really great session on arthritis and rheumatology, led by one of our other co-leaders, Nate Nelson-Maney and Dr. Jonas. I'm going to turn stuff over to Paige, one of the other MD PhD students, who is going to handle all the introductions tonight. If you have any questions, please feel free to put them into the Q&A or reach out to our Gmail, uncminimedschool@gmail.com, for any technical issues. Here you go.
Hello, everyone. I'm happy to introduce tonight Nathan Nelson-Maney before he gives his talk. He's our student speaker tonight and is going to do a little bit of an intro for us. So just a little background on him. He is currently a fifth year in the MD PhD program and previously completed his undergrad at UMass Amherst and did some research at Brigham and Women's Hospital before coming to the program here. He's now completing some of his research in the lymphatics vascular system and has a clinical interest in rheumatology. So I'm happy to hand it over, and here you go.
Thank you, Paige. All right, let's just get these slides going. All right. All right, so hi everybody, my name is Nate, and I'm going to talk to you today a little bit about arthritis and rheumatology. First things first, I wanted to cover what a rheumatologist actually is, because with a lot of other physician like classifications, you can kind of deduce from the name what they do based off of like cardiology is the heart, pulmonology would be the lungs, but like what actually is a rheuma to something. Just to go for completeness, a rheumatologist is an internal medicine physician. So they went to medical school, internal medicine residency, and then did a fellowship in rheumatology. And they treat systemic autoimmune diseases primarily. So what those are is when the immune system targets the cell. Generally, these present in some sort of way that is initially in the musculoskeletal system. So like joints and bones and muscles and things like that. But they really present through the whole body, even though the things people think about with rheumatologists is arthritis. And so to understand what rheumatism is, I think it's good to look back into the past and talk about a little bit of etymology. And so rheumatism is an old term that dates back to the 17th century. From the Greek word rheuma, which means stream. It's from this dated system of like the bodily humors of medicine. Now it usually refers to conditions that cause chronic pain or inflammation in the joints and connective tissues. And even though bodily humors are not how we think about medicine now, it's actually not that far off because the immune system, part of it is housed in the blood, and that kind of is like a stream that runs through the body. So it's kind of close, but rheumatologists generally deal with the immune system. And they treat things like rheumatoid arthritis. This little chart is just to show you it affects the whole body and not just the joints. But they also treat things like psoriatic arthritis, systemic lupus erythematosus or lupus, vasculitis, which is inflammation of the blood vessels, and many other conditions as well. So we're talking about rheumatoid arthritis today, though. And let's just sort of break it down some more with some more etymology. Arthritis means joint disease, and an arthron is a joint. So that's sort of, I think, understanding the root words helps understand what we're talking about, and kind of demystifies the words. Rheumatoid arthritis is a subsection of adult onset arthritis, which is different than things like osteoarthritis or spondyloarthritis. Osteoarthritis is commonly what we think of when somebody has what we would call a degenerative disease of the joint, although current research in that field is actually showing it's not solely mediated by just damage to the joint. And I have this chart up here just to show that arthritis is really diverse, and it can present in childhood or adulthood, and they're all really different diseases, and they present very differently in the joints and throughout the body. We'll talk about RA. So just some quick general anatomy about the joint. Joints are where two bones meet. And generally, between the two bones is cartilage. Cartilage is a firm but pliable tissue that cushions and allows the bones to slide over one another when you move, sort of like any joint. The joint is also covered by a synovial tissue layer, and outside of that is a fibrous sort of capsule to the joint. Additionally, inside the joint cavity is a fluid called synovial fluid or joint fluid, and that acts sort of like oil in an engine and lets the bones move across one another, providing a relatively low friction area, so you can move your hands and legs and arms and things like that. There are lots and lots of types of joints in the body. We think of joints being like our elbows and knees, just simple hinge joints, but there's also things like saddle joints that allow for a lot of different motions. And there are some joints that are fused and don't really move, but we can still get arthritis in those, like the joints in the pelvis. So arthritis, again, is inflammation in the joint space. It's hallmark of this is immune cells that react to something in the joint, come in there and cause damage to the joints. Inflammation is a really key part of the immune response. And the immune response is vital for the body's response to things that are not supposed to be there. So in this image here, we can see that there's an injury like this splinter. So something harmful enters the body. The body recognizes that something bad is there, and then it sort of scrambles the troops and brings immune cells and things like that to help process the bad thing that's in the body. Inflammation is characterized by redness, swelling, heat, pain, and loss of function in the area. So anytime, imagine you get a cut or like a splinter or something like that, it gets red, it swells up, it gets warm, it hurts, and you lose the function to that area. And those are all characterized by how the immune system is interacting with the tissue around it. And so these two pictures down here of these folks is just to demonstrate that even though I said inflammation is characterized by redness, swelling, heat, and pain, it can look different on different people. And so there's a lot of complexity here and a lot of nuance the way that we think about this. Just like I said, it's very complex. The immune system is very complex. There's a lot of different cells that are engaged in the immune response. And there are a lot of these things called cytokines, which are represented by the mostly IL dash numbers in this chart. The point of this is really to show that this is like an arcane thing. And it's like, we're like sitting here like wizards learning these arcane numbers and symbols that don't really mean anything to what the actual function of these cytokines is. So I think it's easier to start with the cells. And so the immune system in general can be split into two categories, the innate immune system and the adaptive immune system. The innate immune system is the first responders. It happens fast, within hours and minutes. And we can break it down like this. This is another complicated chart, but there are three take-homes from it. The innate immune innate immune system responds to things called like danger signals. These are called like pathogen-associated molecular patterns. They're things that are shared between pathogens that signal to the body this is not supposed to be here. And there are receptors for these danger signals. And when those receptors find the danger signal, stuff happens in the cell and the cell produces cytokines. So these cytokines are kind of like an emergency signal or a flare that calls in other types of immune cells to the area. And it helps refine the response and decide what the body's going to do with the thing that's not supposed to be there. Most common cells, or some of the more important cells, I should say, in this response are macrophages and antigen-presenting cells. Macrophages, they engulf antigens that are not supposed to be there, or bacteria or things like that. They process the invader into smaller parts that can be communicated to immune cells. And they basically take this signal and say, I found this, it's not supposed to be here. You should look for this down the road. And so here we just got a little graph. The virus infects the cell, and the macrophage or antigen-presenting cell or dendritic cell grabs part of the bad thing, chews it up, and turns it into something that is presented to a different immune cell down the road. For now, that's really what we need to know about the innate immune system, and we can move on to the adaptive immune system. So this is mostly composed of B cells and T cells. And so talking about B cells are actually sort of an immature form of a more mature plasma cell. B cells are called B cells because they mature in the bone marrow. And their main function is to monitor and make antibodies, or turn solely into antibody-producing factories, what plasma cells are. Antibodies are just the very, very targeted tag for things that are not supposed to be in the body. So if you're infected by a virus, the innate immune system would catch the virus, break it up, and present a target to the B cell. And if the B cell makes the right antibodies, the B cell will get turned into overdrive and produce a lot of antibodies, which will go throughout the blood and find those little bits called antigens throughout the body and mark that for being destroyed. There are also T cells in the in the adaptive immune cell system. And T cells are called this because they mature in the thymus. There are many, many subtypes, but we're just going to break them into cytotoxic and helper T cells. Cytotoxic T cells are basically T cells that recognize normal cells in the body that are too sick with an infection to proceed, and they destroy that cell, which helps us find the thing that is not supposed to be in the body if it's living inside cells, and remove cells that are making more of the bad cell. In addition, there are helper T cells. There's a lot of types of helper T cells, but the important ones that we'll talk about are helper 1, helper 2, and helper 17 type cells. And they're called this through kind of largely arbitrary means. But Th1 cells respond to intracellular viral and bacterial infections, and they produce some cytokines that are specific to them, like interferon gamma and TNF alpha. And Th2 cells, or helper type 2 cells, they respond to more multicellular pathogens like worms or other sort of larger parasites. And they produce a very specific signature of cytokines as well, like IL-4, IL-5, and IL-13. And then finally, Th17 cells, which are actually somewhat more recently discovered. And they're more involved in the extracellular bacteria and fungi response. And they produce IL-17, TNF alpha, and IL-1 beta. Those are all kind of like arcane jargon words again, but they will come up down the road. There's also cells that have memory, and so they respond to the same thing that they saw earlier. Finally, we're going to talk about cytokines really quickly. Cytokines are a chemical communication between cells. most immune cells can make and produce cytokines. And which cytokines are released by the cells determine which cells show up and what happens when the cells do show up. We call ones that are pro-inflammatory, ones that bring cells in and generally destroy the invaders and the tissue around it, just kind of by coincidence. We have ones called anti-inflammatory, which generally tamp down the immune response. And so think about it like a flare or a 911 call. You bring in the troops or resolve it, depending on what the point is. And these are all really specific and targeted. So the last thing is if you have a ghost, you want to call the Ghostbusters. So you want to use the right thing to call. And last slide. What's really interesting about rheumatology is there's all this complexity in the immune system, and rheumatologists use these drugs that are really, really targeted to specific parts of the immune response. And so you can use these drugs and stop one of the parts of the immune response that's broken while leaving the rest of the immune response largely intact. They're not perfect, and people who take these drugs do have to think about like maintaining their infection risk. But largely in the past maybe 10 or so years, these drugs have started to come on the market and have really improved the care patients with rheumatologic diseases get. And with that, that's all I have. So thanks for coming, and happy to take any questions. I know that was a bit of a whirlwind for. Okay, yeah.
So in rheumatoid arthritis, what is the foreign thing?
That's a great question. And if I knew that, I'd be, oh, right. So the question is what, if the immune response is triggered by something foreign that's not supposed to be in the body, what is the thing that triggers a rheumatoid arthritis or some other type of inflammatory disease? And the answer to that is, that would be great to know. There are some hypotheses as to what types of things trigger these diseases. So these are diseases of the connective tissue. So it's likely some component of connective tissue or something that's been modified about connective tissue. This is a bit much for the general topic, but there are things called citrulline proteins, which there have been some hypotheses to suggest that those can play a role in the initiation, but we don't know what the actual thing is, and it might be different for every patient.
That's something that's foreign to the body, or is that something that's
Yeah, so probably. The citrullination of peptides is a normal process in the body, but the handling of those peptides might be what's the root cause. Yeah. Mm-hmm. Yeah. So I think Dr. Jonas is going to cover that. So I won't step on her toes, but it's the range is wider than you'd think, and it can present in a lot of different ways. So I don't think there's like a true hallmark. I think we'll cover that next few minutes. Any questions? Yeah. Great question. Oh, the question was, how dangerous is swelling around joints? And that's a great question. And it also, like everything I said, kind of depends on what the type of swelling is. So if, say, you have an injury to your joint, the swelling itself is not dangerous to the joint. That would be part of the normal response. The problem with things that are inflammatory is that the cytokines and immune cells that are brought into the joint by the immune response can cause damage to the bone and the cartilage, and can activate cells that remodel the bone and cause it to either grow or be decayed in sort of a pattern that's not normal. And so all of that will play a role in the damage that happens to the joints in an inflammatory arthritis. How are we doing on time? Should we wrap up? Yeah, so thank you all for your attention and for coming. We'll take a few-minute break while we switch over our slides, and we'll start back up in about 5 minutes at 5:55. All right.
Okay, great. I think we're going to go ahead and get started with our faculty talk for the night. I am really excited to be able to introduce Dr. Jonas to us tonight, who will be talking to us more on the topic of rheumatoid arthritis. Just a little background on her. Her clinical interests are in the evaluation and the management of patients with inflammatory arthritis, which can include rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, and enteropathic arthritis, all very big words. She has a very strong interest in medical education and educational scholarship, and she is highly involved in teaching at many different levels, all the way from undergraduate to medical student to rheumatology fellows. And we're lucky to have her here tonight to teach us. So without further ado, here's Dr. Jonas.
Thank you so much. It's a pleasure to be here at Mini Medical School. And I want to just say Nate did a great job and presented a lot of stuff. And so, and what I like about it is that it generated a lot of questions amongst our learners today that have just teed me up perfectly to answer the questions. So we're going to talk about rheumatoid arthritis. The other thing we're going to do is take some of what Nate has shared with us and try to put into a clinical context. Because sometimes when we're studying science, it can be like really overwhelming. I don't have to tell you all that. But if we can say, how does it affect our body? And how might it inform how we treat a patient, a person, a human? I think we can actually solidify that knowledge and learn it better. So I'm going to try to sort of take what we've learned and apply it to a patient. Okay, so here are our learning objectives for our session this evening. First of all, we're going to talk about the clinical manifestations of rheumatoid arthritis. Again, answering some of the questions. Oops, we're going. Okay. Not going to go away. Okay. We're going to talk about clinical manifestations, including the joints, but other organ systems. And Nate actually teed me up perfectly for this, because rheumatic diseases we think about as being primarily diseases of the musculoskeletal system, but actually most of our rheumatic diseases can affect any organ system, and rheumatoid arthritis is no exception to that rule. So we're going to talk about that. And then we're going to learn about how our understanding of the immune system, all of that alphabet soup that was in all those pictures, really has informed what we understand about arthritis, rheumatoid arthritis, and other kinds of arthritis and other rheumatic diseases, and how that has led us to some really, really effective therapies. So that is our goal. So we're going to start with a case. This is our patient. She's 47 years old, previously healthy, and she comes to the clinic today for swelling in her hands. And she tells us that she's been stiff for about 3 months. She gets up in the morning, and it takes her about an hour to get her hands kind of worked out. She has pain and swelling and stiffness, which improves with activity. She got herself some ibuprofen at her local pharmacy, and she's had some response. And she's also noticed that her eyes are very dry and she's really tired. And you do a physical examination and you notice that there's swelling of the small joints of the hands. She's got some nodules here at her elbows. Her eyes are a little red, but otherwise her examination is normal. And we're going to come back to our patient at the end. But we're going to jump into our talk on rheumatoid arthritis. So this is a multi-system inflammatory disease. Usually the first sign is a symmetric inflammatory or polyarthritis in the hands and the feet. And so symmetry means both sides are involved. Inflammatory means there's signs of inflammation, which Nate talked to us about. and it's a polyarthritis. So there's multiple joints. Nate mentioned that there were many, many different kinds of arthritis, and each kind of arthritis sort of has its way of presenting. And so when I say a symmetric inflammatory polyarthritis, that really describes a patient with rheumatoid arthritis. This is a disease that affects about 1% of the world's population. So think about that. That's a lot of people. Women are affected more than men for reasons we do not understand, probably about 3 or 4 to 1. And the peak age of onset is between 45 and 65. Having said that, we can see older teenagers, 16, 17, 18, who can develop rheumatoid arthritis. And I've had patients as old as 93 present with their first episode of rheumatoid arthritis. So it's very, very broad, but the peak onset is in these sort of middle years. I want to just talk about the pattern of the joint involvement. This is really important. So pattern of joint involvement means which joints are involved. And we can see here in rheumatoid arthritis, it often involves the PIP joints, and the MCP joints, and the wrists. And I'm going to compare that to osteoarthritis, which usually involves the PIP joints, the DIP joints, the most distal joints, and then often the base of the thumb. So even when we're talking about just the hand in a patient with arthritis who comes to your clinic, if you can determine the pattern of the joint involvement, you often can make a diagnosis. Now, lots of other joints can be involved. I mentioned that rheumatoid arthritis often involves the feet early, and it usually involves the ball of the foot. So where we're standing on the ball of our foot, the midfoot, but not usually the more distal toe joints. And in osteoarthritis, by far, the first metatarsal phalangeal joint is commonly involved. So the pattern of joint involvement can be different in different kinds of arthritis. So what are the risk factors? Who is going to develop rheumatoid arthritis? And there's some controversy about some of these. And the ones that I've put in purple are the ones that I think are very well established. So women more likely than men. Exposure to tobacco. So if there was not another good reason to stop smoking, here's another one, right? So smoking exposure is a risk factor for the development of rheumatoid arthritis. There's also some thought that air pollution, occupational dust, and a number of other sort of environmental toxins may be increasing your risk for the development of rheumatoid arthritis. Low vitamin D levels have been associated, but the ones we know for sure are being a woman and smoking. There are also things that will decrease your risk for rheumatoid arthritis: consuming fish and other foods that are high in omega-3 fatty acids, and interestingly, moderate alcohol intake. I'm not suggesting everyone should go out and drink to prevent rheumatoid arthritis, but if we look at large groups of people, you're much less likely to develop RA if you drink not a little bit, not too much, just a moderate amount. There are also some genetic risk factors for the development of rheumatoid arthritis, and I've highlighted just one at the top, the HLA-DRB1 gene. And these are genes that encode the class 2 HLA-MHC complex. And why this is important is that this is a part of the immune system that helps us recognize foreign antigens. So this, if you have a particular allele of the HLA-DRB1 gene, you're at higher risk for the development of rheumatoid arthritis. Now, this slide has a bazillion other genes. I don't want you to worry about that, but the HLA-DRB1 genes are the most important ones. Now, this slide looks a lot like one of the slides that Nate showed us, but I want to point out a few things because this slide sort of encapsulates the pathophysiology of what we think the pathophysiology of rheumatoid arthritis is. And so you have an antigen-presenting cell up here in the corner, okay? And you have this foreign or autoantigen. So one of our learners asked in the last session, what is the antigen? What is the cause? What is turning on the immune system? And that's a brilliant question. And I don't know the answer. And I don't think anybody knows the answer. I think there probably are many, many different antigens that may turn on this immune response. And it's really interesting. you know, there's been some thought, is there an infection that can trigger this? Many people with rheumatoid arthritis will say, I felt perfectly well until I got the flu or some infection or whatever it was. And we're seeing patients who've gotten COVID who develop an immune response that looks like rheumatoid arthritis. So I think there could be an infectious trigger. There may be these environmental triggers, smoking, silicates, those may be autoantigens. Now, women get it more than men. Could this be a sex steroid hormone? Could this be an estrogen problem? Probably not, but it's an interesting thought. So, you know, what it is that turns this on, what this foreign or self-antigen is not known. And probably in each individual patient, as Nate mentioned, it may be a different antigen, okay? But what we know is you have a genetically susceptible host responds to some antigen, and this naive T cell starts to get activated. Okay, we activate this T cell, and what this T cell does is it turns on our macrophage. Remember, this is part of our innate immune response. And then it turns on a B cell, which is part of our adaptive immune response. And you can see that there's this sort of cascade of different mediators that are going to turn on the immune system. So this B cell turns into a plasma cell, which makes an autoantibody. The autoantibody turns on that macrophage, which acts on a cell, a chondrocyte in your cartilage or an osteoclast in your bone. And that is part of the immune response that we see starting and then ultimately perpetuating to the development of rheumatoid arthritis. So it's a busy slide. There's a lot of stuff on here, but I think it helps you understand that there's inflammation at so many different levels. And I will also mention so many particular targets that we can use for our therapeutics. So this is going to be review. This is the structure of a normal joint, and you can see we've got the bones, we've got the cartilage sitting on top of the bones. Inside here, we have the synovial cavity. And the synovial cavity is very important because probably the first place where there's something abnormal happening in rheumatoid arthritis is in the synovial lining. And I'm going to show you some pictures. So on the left panel, you can see normal synovium. This is a thin, lacy tissue. Water moves readily across this membrane. Very, very healthy. In early rheumatoid arthritis, you can see that there's lots of cells which infiltrate this tissue. And the cell layers get very, very thick. Water is not moving readily across this membrane, and the tissue is getting very, very thick. Eventually, we get what we call a rheumatoid pannus, and you can see that the synovium is invading this tissue, this pink tissue with these little cells, which are chondrocytes. And the tissue can invade into the bone. So this synovial layer gets very thick. It gets infiltrated with T cells, usually CD4 positive T cells. And then ultimately this tissue grows into the cartilage and into the bone, causing damage to the joint. So somebody asked the question, what happens when there's swelling and can it damage joints? This is exactly how this happens. And this can happen actually fairly rapidly if you're not treating your patient. So we mentioned that this is an autoimmune disease where your body is making something that's attacking its own tissue. Antibodies are part of that. There are two different kinds of antibodies that we see in rheumatoid arthritis. One of them is a rheumatoid factor, and then the other one is an antibody to citrullinated peptides, which Nate talked about a minute ago. And if you have antibodies to these citrullinated peptides and they're present in a high titer, I know and you know as the doctor taking care of this patient that that patient is at higher risk of developing joint damage. So our autoantibodies are markers of disease, and then they can also predict outcome. I'm going to skip over, well, I'm not going to skip this slide. It's complicated, but I just want to point out a few things. Number one is you can be susceptible to rheumatoid arthritis and have no symptoms and show no signs of autoimmunity. So you have the right genes. You might have been exposed to something that's your trigger. And then there's this sort of relative period of time where you're completely asymptomatic. And then you can develop something we call preclinical RA, where if we were measuring cytokines in your blood, we might measure them to be higher than normal. And you may be completely, again, asymptomatic. So a lot of this is sort of going on subclinically until you develop early symptomatic autoimmunity. And in this sort of phase, you may start to have stiffness, you may start to have pain, you may start to feel like something's not right, like maybe I feel like I'm getting the flu. And then eventually over time, you may develop this swelling of the synovium, which we see here in red, and then we'll be able to diagnose rheumatoid arthritis. So this can go on for some period of time before you actually develop clinical symptomatology. So just a couple of pictures of a patient, well, these are different patients with rheumatoid arthritis. And what you can see here is this sort of fusiform swelling of the PIP joints, these are proximal interphalangeal joints of the second and third digit on this left hand. This patient has swelling of the MCP or metacarpal phalangeal joints. That's these knuckles right here. And then as well, the proximal interphalangeal joints. And you really kind of get the feeling like these are really, really swollen. And they can be really quite tender and very painful. Now, this is the hands of a patient with very long-standing rheumatoid arthritis. This may be somebody who was not treated aggressively or diagnosed early, although every now and again we see somebody who we diagnose early and treat, and this is how things land. But we used to see these kinds of hands much more 20 years ago before some of our newer therapeutics. And what you can see here, here's our metacarpal phalangeal joints. And then you can see that the joints are actually subluxed. And what I mean by subluxed is, normally each side of the joint is kind of lined up. And when they get subluxed, they kind of go that way. And you can see how there's sort of a step off here at the MCP joint, okay? And then the fingers are deviated toward the side, toward the ulnar side of the hand. And then on this hand, on this left hand, this patient will not be able to extend her digits because of that subluxation. So this is severe deforming rheumatoid arthritis. This is what we're trying to avoid. And this is some x-rays of patients with rheumatoid arthritis. This is a patient with pretty early disease. It really doesn't have any joint damage that we can ascertain. There may be a little bit of something we call periarticular osteopenia, of loss of bone mineral density here at the joints, but otherwise these hands look a-okay. As opposed to these hands on the right, you can see there's subluxations at the MCP joints. The digits are sort of going toward the ulnar side of the hand. This is the ulna on this side. This is the radius. So we call this deviated toward the ulnar side of the hand. And also the bones of the carpus of the wrist are all squished together. Look over here, you see there's nice space in between the carpal bones, and here they're kind of all smushed together. So this is a patient with long-standing, poorly controlled rheumatoid arthritis. And the feet. The feet are really sometimes much harder to examine than the hands, but this is the patient who has swelling of the metatarsal joints. You can see this toe is kind of squishy, and there's some redness over that. On the bottom of the foot, you can see these areas of swelling. They can be very, very painful. And some patients will say they feel like they're walking on marbles because they are. There's a lot of soft tissue swelling there. Now, the same is true of the feet. You can have mild disease and severe disease. On the left, we have a patient who's really developed lots of destructive arthritis of the ball of the foot. Here on the right, this patient has less severe disease, but lots of erosion. You see all these arrows are places on the bone that has gotten eaten away by the synovium that's sitting next to it and is eroding into the bone. So that's generally a sign of severe disease and makes us, when we see a patient in the clinic, want to get really aggressive with our medical management. So I mentioned a minute ago that this was really a disease of the whole body, and up until now, we've really just talked about the bones and the joints. but almost any organ system can be involved. The heart, the lungs, the skin, the neurologic system, the hematologic system, the bones, the eye, interestingly, and even the kidney can be involved, although I have to say it's so rare, I don't think I've ever seen that, but it's always on the slide. So this is something we often see in rheumatoid arthritis. And remember I told you about our patient had some nodules on her elbows. And hers were not quite this prominent, but this is a nodule at the elbow of a patient with rheumatoid arthritis. Here's some nodules over the dorsum of the hand. You can see that. And if we were to take one of those nodules off and look at it under the microscope, we would see this very characteristic histology of a rheumatoid nodule. And if you're not sure what these nodules are, you take it off and look at it under the microscope, and sometimes you'll see this, and then you know the patient has rheumatoid arthritis. We rarely do that, but if you're uncertain, that can be done. So rheumatoid arthritis can involve the heart, and two major things can happen in the heart. One is inflammation of the pericardium. So this is a normal heart. This is the pericardium, which is the tissue that surrounds the heart. And in pericarditis, or inflammation of the pericardium, you see that here, that can be a manifestation of rheumatoid arthritis. And your patient may present with usually chest pain or sometimes shortness of breath. And that pain is often worse if you take a deep breath or if you lay down. So if someone's having chest pain, you want to ask questions. The other really interesting thing about rheumatoid arthritis, as well as other systemic rheumatic diseases, is that patients with these kinds of systemic rheumatic and inflammatory diseases have a higher incidence of coronary artery disease. So having a heart attack or having a stroke, something like that. So even young people with rheumatoid arthritis can have heart attacks much younger than you would have otherwise expected. And so what happens is they develop atherosclerosis, development of plaque in the vessels, loss of blood flow, and then potentially a heart attack. And I have, in fact, I swear to you, today I was in the clinic and I was reading notes on patients that were coming in, a patient with rheumatoid arthritis. I'm reading the old notes. I noticed she's just been to the cardiologist because she's in her 60s, but she's like a kickboxer and she's a very avid exerciser. And she noticed that, you know, her exercise tolerance was lower. And her mom had had a heart attack very young, and she knew the cardiologist who took care of her mom. She called him up and said, hey, you know, I'm noticing that when I'm kickboxing, I can't do as much and I'm feeling more short of breath. He brings her in, they do a cardiac cath, and she had a 95% lesion of her left anterior descending artery, which they ballooned open. And had she not come in for that, she probably would have died. So anyway, Finn, otherwise healthy, rheumatoid arthritis, horrible coronary artery disease, right? And another patient today, juvenile arthritis, who also had a heart attack sort of out of the blue. So that's something we think about a lot and make sure that our patients are getting screened. So rheumatoid arthritis can involve the lung. And about 10% of patients with rheumatoid arthritis will have clinically significant lung disease. Some patients will have subclinical disease, so they'll have abnormalities in their chest x-ray, but they really won't have symptoms. The risk factors for lung disease in rheumatoid arthritis include older age, men more than women, and if you smoke. If you have higher disease activity, in other words, if your arthritis is not well controlled, or if you have a high titer rheumatoid factor or CCP, you're at higher risk of having lung disease with your rheumatoid arthritis. And the eye. And I think the eye is so interesting. There's so many rheumatic diseases that affect the eye. And when patients come to my clinic and I ask them about their eyes, they're always shaking, you know, sort of scratching their head like, why is she asking me about my eyes? I came here because my hands hurt. And the reason is because the eye can really tell us something about someone's disease state. In other words, if you have a patient with rheumatoid arthritis who has eye involvement, it probably means that their RA is probably more severe or is going to become more severe. And remember our patient had red eyes, okay? When I have a patient comes to my clinic with rheumatoid arthritis, I'm always looking in their eyes. I mean, I always look in people's eyes anyway when I talk to them, but I'm also looking to see, are their eyes red? And every now and again, someone will come in and I'll say, hey, what's going on with your eyes? What do you mean what's going on with my eyes? Okay, we have to talk about that. Lots of different things can happen in the eye. The cornea can be involved, keratoconjunctivitis sicca, which is a very fancy word that means my eyes are dry. And very many patients, about 30% of patients with rheumatoid arthritis and 30% of patients with almost every rheumatic disease have dry eye. They can develop something called peripheral ulcerative keratitis, which means peripheral of the eye, ulcerative, causing ulcers, keratitis, inflammation of the cornea, which can be really destructive. And occasionally I'll see patients like that. The sclera, which is another part of the eye, can be involved. And this is a patient with very severe nodular scleritis. You see how angry that eye is. And this is actually an emergency. These patients need to get to the ophthalmologist right away. So here's some lung pictures. I don't know how that got out of whack there, but this is a patient with interstitial lung disease. You can see how hazy the lungs look on this CAT scan. And this is a patient, this is actually a patient of mine with pleural disease. So the pleura, I showed you the pericardium around the heart. The pleura is the tissue around the lung, and you can have pleuritis or inflammation of the pleura in rheumatoid arthritis. And this is a patient of mine who actually, I remember this because I think it was like Christmas or New Year's or one of these things, you get the I can't breathe call, and I'm like, I'll meet you in the hospital. So this was Christmas Eve, and we can actually take that fluid off and the patient felt significantly better. So let's talk about treatment. So we talked about some of the articular manifestations. We talked about some of the other body parts that might be involved. What are we going to tell our patients? How are we going to treat this? I like to start with non-pharmacologic therapies for rheumatoid arthritis. Everybody wants to know, what pill can I take to make this go away? But there's a lot of things that we can do to really help patients with rheumatoid arthritis that do not involve medicine. First of all, patient education. This is really important. Understand your disease, understand the kinds of things you need to know, when to call your doctor, when not to call your doctor, what should I be on the lookout for, what are the urgent things, if my eye turns red, those kinds of things. Physical activity is extremely important, and this is where I think we've really evolved in rheumatology. Back many years ago when I was training, we used to tell everybody to go to bed, just rest. Everyone's going to get better. Well, it's completely untrue. You go to bed and you're going to get more stiff and more sore and more tired, and it's going to be harder to get you up and moving. So now we really, really promote exercise and physical activity. Flexibility, resistance training, and aerobic activity, all extremely important. So keep moving. That's not to say if a patient has a very inflamed joint that they're going to run on it, right? So sometimes it'll be very gentle exercise, and depending on how your patient is doing, more aggressive exercise. There are a lot of complementary therapies that our patients like to participate in: acupuncture, Ayurvedic therapies, Tai Chi, all kinds of things. I'm all about it if it helps. But I think these things are really very important. What's interesting is that the American College of Rheumatology is now developing guidance for doctors and for patients about these kinds of therapies and how to use them, and we're waiting for that to be published. It's under development and very, very soon. But let's talk in the last few minutes about medicine, because that's really the lion's share of what we're going to be doing in our clinic. So there are lots of medicines that might be helpful for pain and inflammation. And I mentioned in our patient that she had taken some ibuprofen, and that was very helpful. Ibuprofen is a non-steroidal anti-inflammatory medicine. You can buy it at any local drugstore, and it may control symptoms, but it is not going to prevent the progression of the disease. And so where we really want to make some progress is to start our patients on disease-modifying anti-rheumatic drugs, or something that we call DMARDs. And there's a long list of DMARDs. This is probably the Reader's Digest version of this, but there's sort of three categories. The CS, or conventional synthetic DMARDs, these are kind of older drugs, but they're good. Methotrexate, leflunomide, sulfasalazine, and hydroxychloroquine are sort of our main drugs. Methotrexate by far is our drug of choice, and most patients with rheumatoid arthritis are started on methotrexate for their initial therapy. Patients who have an inadequate response to conventional synthetic DMARDs may either be started on a biologic DMARD or a targeted synthetic DMARD. And the biologic DMARDs are really where we've made such progress. And actually, the first biologic DMARD for rheumatoid arthritis was in 1998. Infliximab and etanercept, 2 TNF inhibitors, were released that year. The infliximab was actually initially, I'm trying to remember if it was initially indicated for inflammatory bowel disease and then rheumatoid arthritis, or the other way around. But either way, the TNF inhibitor has been around since 1998. There are some patients who respond beautifully to TNF inhibitors, and that's great, but many patients do not respond. And that has led to lots of new therapeutics: IL-6 inhibitors, T-cell co-stimulation inhibitors, and anti-CD20 monoclonal antibodies. And each of these drugs, I'm going to show you in a minute, work at a particular area that we talked about in this pathophysiology of rheumatoid arthritis. And more recently, we have our targeted synthetic DMARDs, our Janus kinase inhibitors. If you watch TV, there's always like some commercial about one or another of this. So the JAK inhibitors are Rinvoq. I think that's on TV a lot. I'm not going to I'm not selling any drugs here. Nobody's paid me to say that. Trust me. Okay. So what are our sort of strategies? And we have developed what we call a treat to target strategy. Our goal is to decrease the number of swollen and tender joints and improve function. And we're going to keep at it until we get there. Methotrexate monotherapy as a single drug is strongly recommended as initial therapy in patients with moderate to severe disease. And as I mentioned, in patients who have an inadequate response to methotrexate, we would add either a biologic DMARD or a targeted synthetic DMARD. The other thing is I didn't talk about prednisone or steroids. Prednisone or steroids can be very helpful in patients with a lot of active disease, but has a lot of side effects. So we really our goals these days is really to limit steroid exposure. But sometimes we have to get people out of bed and get them moving and get them feeling better. So this is to show you these current therapeutic targets that we just mentioned. So for example, our TNF inhibitors act in a number of places in RA pathogenesis. It can act at the level of the macrophage, at the osteoclast level of the neutrophil, the fibroblast-like synoviocyte. So you can see there's a redundancy in the immune system. And if we inhibit TNF, we can inhibit inflammation at all of these levels. Same is true at IL-6. You can see that IL-6 here is important in B cell activation, as well here in macrophage activation. So all of these medicines which affect these cytokines can affect the immune system and our response to whatever it is that's turning it on. So let's go back to our patient. This is our 47-year-old woman who had had 3 months of stiffness. She'd had a modest response to ibuprofen. She had dry eyes and fatigue. She had swelling of the small joints of the hand, small nodules at the elbow, mild redness of her eyes, but otherwise all was well. We did some laboratory testing. She was mildly anemic, which is not uncommon in patients with early rheumatoid arthritis. She had both a rheumatoid factor and a CCP that were elevated. These are our autoimmune markers for rheumatoid arthritis. And her CRP, or C-reactive protein, which is a marker of systemic inflammation, was elevated. So all of that together tells me that this patient has rheumatoid arthritis. And these are her x-rays. She had normal x-rays. And this is good news because our goal really is to prevent damage. Once the joints are damaged, once there's erosion of bone, there's no medicine on the planet going to solve that problem. So if we see somebody with early disease who has normal x-rays, we know that we're really going to be in good shape. And as long as we're aggressive, we can prevent damage. So what is our treatment paradigm for our patient? Number one is we're going to talk about RA. We're going to talk about exercise. We're going to talk about nutrition. Nutrition is probably really very important, and we don't have time today to really talk about that, but maintaining a healthy body weight, probably limiting sugar. Sugar is very pro-inflammatory, and there are probably some diets that are better for people with inflammation. The Mediterranean diet has been studied quite a bit in that regard. And then, of course, we have our pharmacologic management. We're going to begin methotrexate in this patient. She can use NSAIDs or ibuprofen if she needs it. We're going to try to avoid steroids if we can, and I think we probably can in this case. And the other thing we're going to think about with this patient is the bone health. Patients with rheumatoid arthritis are at higher risk of developing osteoporosis and fractures. So is our patient exercising? Is she getting enough calcium and vitamin D? And when she's at the appropriate age, are we going to measure bone density? And then for our women who have childbearing potential and sort of in the range to become pregnant, you cannot become pregnant when you're on methotrexate. It's not safe. And so we want to make sure that our patients are using contraception if they're going on methotrexate, and to have those conversations. So I'm going to wrap us up here and then open for questions. RA is a multi-system disease. I hope I've proven that to you with all my discussion of the different organs. But it's characterized by a symmetric small joint arthritis. In addition to the joints, many, many organ systems can be involved. And our knowledge of the immune system has led to better therapies and improved outcomes for our patients with rheumatoid arthritis. So I thank you all for having me. I appreciate the invitation to be here, and I am open for questions.
Got one. Is it known if the apparent effect of moderate health of study design and analysis of studies, or does it appear to be a true effect?
Yes, I do. You know, it's a very, very good question. And when you ever see something like that, you always have to sort of scratch your head and say, you know, is this really real? I believe that data actually comes from the Harvard Nurses Health Study, which was an extremely well-designed epidemiologic study. So I think that the finding in that population is valid. Whether that's valid in other populations, I really don't know. So I'm not advising anyone to drink moderately to prevent rheumatoid arthritis. Let me make that perfectly clear.
I guess to add on to that, what is like your definition of moderate?
Yeah. So let me talk about what really mild is and what severe is, and then everything in between is moderate. How about that? That's easier, right? So mild disease is somebody who has, you know, very few swollen or tender joints, responds completely to an anti-inflammatory, and doesn't have a high CCP antibody. So sort of low risk markers. Someone with severe disease has 10 or more swollen and tender joints, might have a high rheumatoid factor or CCP, or evidence on their x-ray that they're about to or have already developed erosions. Moderate disease is in the middle, but I don't think there is a standard definition of that by any way, shape, or form. Yeah. Yes.
Are there diseases that are
Yeah. So so the people online can hear. Are there diseases that RA can commonly be mistaken for? Yes. And that's what we call in medicine a differential diagnosis. So when you see a patient who has signs and symptoms of rheumatoid arthritis, the next thing I'm thinking of, could this be something else that looks like rheumatoid arthritis, but really isn't and might be treated differently? So the major things are osteoarthritis, and I showed you that sort of pattern of joint involvement. We're always going to make that distinction. There are people who have viral illness that can develop signs and symptoms that look just like rheumatoid arthritis. So people with EBV can do that. Parvovirus B19 is a classic. Patients can look just like they have rheumatoid arthritis. Sometimes people with autoimmune thyroid disease like hypothyroidism can present looking like rheumatoid arthritis. So the differential diagnosis is extremely broad.
You mentioned that.
Yeah. Yeah. So the question is, since we think infections can be a trigger over the last few years, is there any signal here? And, when we sit across from a patient, we see one patient. So I saw a patient earlier today who was perfectly well until she had a COVID infection. And then she developed signs and symptoms of another autoimmune disease, Sjogren's syndrome. Sort of made me scratch my head, like, could that somehow be a reaction to this viral pathogen? And the answer is, and she asked me that, and I said, maybe. But there is a growing literature of patients who developed COVID who have developed autoimmune type phenomenon. And in early COVID, and actually, when we were seeing early COVID and patients were really sick before the vaccines and they were in the intensive care units, some of what they had looked like systemic autoimmune disease. They have a lot of high cytokines. In fact, we used some of our rheumatoid arthritis therapies to treat patients with COVID because they had this just what we call a cytokine storm, very high levels of inflammation in their whole body. And the only way to get it under control is high doses of steroids and some of these medicines that we use for rheumatoid arthritis. So we got called a lot. Hey, do you know how to use this drug? Can you help us out? Yeah, we're with you. We're there. And so that can certainly happen. But there is some literature now growing of, large sort of clinics of post-COVID patients or COVID recovery patients where people are developing what looks like some autoimmune syndromes, even with some autoantibodies in their blood. So I think we're learning a lot, and I think there is a growing literature. My sense in the patients that I've seen is if it's post-COVID, they often get sick and then get better and it goes away. I haven't seen very many people who develop an autoimmune disease, don't get better, and then I gotta treat them, right? Because once you start treating them, you don't know whether it was gonna go away anyway or your treatment helped. But it's a really interesting thought because when I showed you that slide of like, well, that antigen like turns this immune thing on, like what is that antigen, right? And the parvovirus story is also really interesting because parvovirus B19, which is a virus, in kids, it's called the 5th viral exanthem of childhood, and it's very, very common. It's not that common in adults. When we see it in adults, they often have arthritis, but it gets better. 3 to 6 months, they're better. They sometimes can have a rheumatoid factor, and then someone thinks, oh, shoosh, this is rheumatoid arthritis, and then you ask the right questions, and you measure, and you can determine whether they've been exposed to parvovirus and figure that out. But sometimes you have to be thinking that has to be in your differential diagnosis, right? Yeah.
Question along I've seen autoimmunity on the rise. To be fair, I haven't read any of the real
Yeah. Yeah, is autoimmunity on the rise? Yeah, it is an inflammatory headline and it does get your attention. And I think there's a few things that we can say. I think we are seeing more autoimmune disease. I mean, I've been in this business now close to 30 years, and I think the incidence is increasing, at least from what I can sort of see lay of the land. The question is, was it always there and we didn't identify it? Did we not know enough about autoimmunity, how to identify it, work it up? All these autoantibodies, which we didn't talk about today, I just talked about rheumatoid factors and CCP. There's a bazillion autoantibodies that you can measure now that we couldn't measure 30 years ago. And is it really just that it's always been out there and now we're looking at it? And I don't know the answer to that question. There's a lot of interest in looking at sort of our environment, right? Changes our environment. Climate change may play a role here. Pollution may play a role here. There's some interesting data, and it's very old data from London, where apparently it's very sooty. There's a lot of, back in the industrial age, lots of that these soot in the air, more highly associated with the development of a rheumatoid factor. So does something in our environments, these environmental things, cause autoantibodies? The other interesting thing is, just because you have an autoantibody in your blood does not mean you're going to have an autoimmune disease. I'm going to let that hang in the air for a minute. This is super important because in my clinic, people get referred to me because someone's measured a whole host of autoantibodies for whatever reason, and 1 or 2 or 3 of them are positive, and then everyone gets nervous, like something horrible is about to happen. A lot of times it's nothing. And we probably all have some low level of autoimmunity going on all the time. And there are certain autoantibodies, ANAs, which we're not talking about today, that about 20% of us have at all times. And this is an antibody that's associated with lupus. And so if your doctor measures it and it's positive and somebody thinks you have lupus, you can see where that's going. Okay. So I think some degree of autoimmunity is something we all live with in our body. When that kind of breaks through and then causes symptomatic autoimmunity is when we sort of get into trouble. So when people say autoimmunity is on the rise, I'm not sure what that means. Is it we're looking at autoimmune serologies, or we really have patients with more disease? There are certainly, we have come so far in our understanding and being able to identify patients with autoimmune disease. So there's that. I think that's really very important. So I think the jury is out, but I think there's something there.
I was wondering if you could speak to the patient experience with arthritis a little more. So for example, our patient we had here, who was caught very early on, first kind of created and is exercising, is it something that could not have problems the rest of life with this and it can be really well managed? Or is it kind of inevitable that it's going to arise with more issues?
Yeah, thanks for that question. So the question is really about the patient experience. What can our patient expect? So our patient, I think was caught very early. She had no joint damage. She was functionally doing fine. We got her on a good therapy, assuming she responds to methotrexate. That may be all it is for her. Now, it doesn't, I'm not guaranteed that a few years down the line, she could break through and need something else. But I think the fact that we're starting at a place with no damage, that's prognostically very good. Every so often I'll see somebody who comes even with early disease, but has horribly swollen and tender joints, not just hands, not just feet, but elbows or knees, or sometimes the temporomandibular joints or the neck, and they can't get out of bed, right? It's amazing, actually. I have some patients that I've been following, who came like that, and we turned that straight around. One of the things that's very hard in early rheumatoid arthritis is to predict somebody's course when they present that severely. In general, when you have a very severe presentation, your course is more likely to be severe, but it doesn't necessarily mean that all of our therapies are not going to be helpful. The patient who's really challenging is the patient who has both a lot of inflammation and has already accrued quite a bit of damage. So this might be somebody who didn't seek medical care, or was unable to seek medical care, or sought medical care in the wrong place and didn't get treated aggressively at the outset, or maybe didn't want to take medicines. We see that not uncommonly. And then, like, sometimes this used to happen a lot more than it happens now. A patient will come in and say, I don't really want to take the methotrexate until I absolutely have to, right? But by the time they absolutely have to, that medicine is not going to work as well, right? So I try to educate my patient about that, is that the longer you have inflammation, the more likely you are to develop damage. So the patient who already has a lot of joint damage, bony erosion, loss of function, and has inflammation on top of it, we can use our therapies to control the inflammation, but they're always going to have that damage. And that's often a struggle. And so sometimes one of those patients will come back to clinic and say, nothing's been swollen, I'm not stiff in the morning, but I'm still hurting. And that's the rough one. Yeah. I showed you a picture of that one patient with the very sublux hands. We don't really see that much anymore. I mean, I have a handful of patients in my practice like that. But if you're getting diagnosed and treated in the year 2023, we hope we don't see that, you know. Yes.
Two questions. One is, so the first question is,
Okay, is it safe to crack your back or crack your knuckles? I think this is an old wives' tale, and I think it's probably perfectly fine. You might want to ask yourself, why am I doing this? Because it freaks everyone around you out. It's like, oh, don't do that. I have my son does it periodically. I'm like, do not do that in the room with me. Yeah, it's really okay. Nothing bad is going to happen if you crack your knuckles. Yes, absolutely can. Apropos of the patient who had a heart attack, right? So, you know, there's a lot of, like I said, other organ systems that can be involved. And even if you think about it, so suppose you have horrible knee disease or horrible hip disease and you can't exercise, right? So it's going to be really hard for you to maintain a healthy weight. It's going to be hard for you to, you know, really exercise your heart. There's so many things that can happen when the musculoskeletal system is affected. So yes, life expectancy can be limited in patients with very severe, you know, inflammatory rheumatic diseases. Yeah. Oh, good. Oh, really? There's a study on this. Okay, I love that. Ask that person to put the reference in the chat, and we can all read about it. Yes. Yeah, so, you know, each of the medicines work a little bit differently. So depending on what you're on, you recall from Nate's slides is that the immune system is really redundant. In other words, you know, there's lots of different cytokines that do the same thing. So if I'm only inhibiting one of the cytokines, one of the other cytokines might just come in there and activate and cause inflammation. So if your disease is responsive to one therapy, it really means that that may be the dominant inflammatory pathway of your disease, and that can change over time. The other thing that can happen with certain of our medicines, particularly our biologic DMARDs, is your body can outsmart the drug and create antibodies to the drugs. We see that in our patients on infliximab sometimes. This is Remicade. And some patients who are on Remicade for a long period of time can develop antibodies to Remicade. It doesn't matter how much you give them, they're not going to respond. We can measure that, and we change drugs, and you're good. The good news is there's so many therapeutics that act at so many different levels of the immune system, as well new ones coming all the time, that it's a very rare patient that I get to the point where I kind of have to throw up my hands and go, we've tried everything. I think that is, you know, that's a very, very unusual patient. Oh, good, excellent, excellent. We're all gonna, that's our homework for tonight, friends, to make sure it's okay to crack your knuckles. Crack on, oh, don't do that. No, it still does give me the creeps, when people, even though I know it's really okay. No more questions? Or are you, we're still looking online. That's listening. Thank you for your questions. This has been fun. And I loved being invited. So have a good evening, everybody. Oh, yeah.
Great. Just like Dr. Jonas said, thank you everyone for joining us tonight. We hope to see you next week where we're going to be talking about colon cancer and gastroenterology. Have a good night.